and I will introduce our speakers. We have two wonderful speakers tonight, Dr. Aaron Olson and Dr. Matthew Studer. Dr. Olson is an associate professor of pediatrics at the University of Washington. He's been a practicing cardiologist for almost 20 years with a background in general cardiology, aortopathies, Kawasaki disease, and cardiac complications of neuromuscular disorders. Dr. Matthew Studer is a clinical associate professor of pediatrics at the University of Washington. He's been a practicing cardiologist for over 15 years with a background in imaging and general cardiology, and is presently the medical director for Seattle Children's Heart Center Regional Cardiology Program, which spans all of Washington, Alaska, and Montana. With that, I will hand it over to Dr. Studer to get us started this evening.
Hello, thanks, Aaron. Appreciate that. I see we're up to 8 attendees, which we're excited about. Aaron just told us that there's a lecture on Friday around measles, and there's 200 people that have signed up for that, which certainly is not surprising. Obviously, a little bit more present of a topic with some real chilling relevance in our day-to-day practice, and so we get it. But just to say thank you to those of you that are joining us tonight. And we certainly want to keep this informal, though we have some formality in the way what we're going to talk about today. But since it's a small group, if you have questions, you have something you'd like to ask, feel free, and we would welcome that. So next slide, please, Aaron. And again, Aaron and I work together at the Heart Center. Good friends, and a privilege of mine to be able to work with him for a while now. And I actually invited him to join us in this topic, given his background and his subject matter expertise. But as in my role as kind of a general cardiologist, but then also overseeing the region, really encountered a lot of the questions as it pertains to issues that kids may have or may be present in a family, cardiovascular issues that have some genetic component and therefore might be inheritable, and then place offspring or first-degree relatives at risk. And so we thought we would spend a little time today talking about some of the genetic basis of inheritable cardiac conditions, get into some specific genetic cardiac conditions that would require referral to us, and talk a little bit about kind of at a 30,000-foot view of some specifics about those topics. And then spend the last third kind of talking a little bit about, after a referral's been placed, what is our approach, and with that, a little bit more of a bent towards genetic testing, and use that maybe as an opportunity to talk a little bit about genetic testing that can be a little bit of a black box, and maybe help provide some clarity around when we might test, who we might test, and the risks and benefits of testing as well. So next slide, please, Dr. Olson. So what is a little bit out of scope of today is genetic syndromes. So we're not going to talk about trisomy 21 or Noonan's or Williams syndrome specifically, but also out of scope is any March Madness bracket advice as well. So if you've got any questions, we are not your two subject matter experts to that, but I do have a few.
Or any measles advice, right?
Or measles advice too. We would not be the people to talk about measles advice, other than get the MMR vaccine.
Yeah.
Next slide, please. So what is in scope, though, is parents that report a family history of cardiovascular disorders during routine clinic visit to you as primary care providers. So, and that may span some of these questions, like my daughter was diagnosed with Marfan syndrome, or insert some other autosomal dominant type of cardiovascular condition. I have other children, and what should I do? My father, paternal grandfather, in this case, died in his 50s of some form of cardiomyopathy. Are my kids at risk? And then my husband had an early heart attack, and what's the risk to our teenage children? Well, what does early mean? Was it really a heart attack? So some things that we can help you tease out in the greater context of, should you then refer that patient, your patient, to us in our cardiac clinic? Next slide. So we'll start with just kind of an overview review of some of the genetic basis of inheritable cardiac conditions, and I'll turn it over to Aaron, and he'll walk us through this first part of our talk.
Thank you, Matt. Great. Thanks for joining us tonight. So it's really important to remember that nearly all of the important genetic cardiac conditions that require referral are autosomal dominant. So the key factor in that is that the screening recommendations are for first-degree relatives of an affected individual. You can see this pedigree here, and so the people with the, I guess the Denver Broncos colors are the affected individuals. So in this case, the first-degree relatives would be these other children. Like Matt talked about earlier, a lot of the family history we get is maybe an uncle is affected, or a grandparent or a cousin is affected. And what should you do in that situation? And really, the key, if it's more than if it's a second degree family, a relative, is really to figure out the status of the mother in this case, or the missing link relative. And so, and this is a situation where we would really recommend you make sure that the mom gets screened first. And again, only if it's their first degree relative. So they don't need to be screened if it's their nephew or a cousin affected. It's really their parent or sibling. One thing that I've really found out in practice is it's really surprising how many people think they've been properly screened, but they haven't when you ask them specific questions. So I get very in depth when I ask families about their screening. So what counts as screening? To me, any cardiac syndrome or any cardiac disease should have an actual cardiology visit with an exam. Sometimes people, surprisingly, the parent will just get a echo or an EKG from their primary care doctor and think that's good, but that's not always good. An EKG, a sticker test, sometimes that's what families or kids call them. If there's a rhythm disorder in the family, an ultrasound or an echocardiogram for structural disorders like cardiomyopathies that we'll talk about, and then genetic testing if a family mutation has been identified. So these are really things that I like to dive in and make sure people have really had this testing. I ask really try to get specific questions. What if that first degree relative, again, the parent hasn't been screened? Then I would strongly ask you, or I would ask you that you recommend that they get a cardiology referral from their PCP, and they should bring as much info about the affected individual as possible. So if it's their brother or grandparent, having the cardiology visit notes or the genetic testing record can really help that referral with their cardiologist be more effective. So really, to summarize this first section, I want you really to remember first degree relatives. So if it's the child who has a first degree relative that's affected, that is an indication for referral. But if it's a grandparent or in this case, maternal uncle, then the parent really needs to be screened first for us to understand the child's risk. Now we will move on to the second section on common inherited genetic conditions that require referral.
And if I may, just briefly, Aaron alluded to a few things. One, screening, and what I think is important is it's screening and it's longitudinal over time. And I think that's one of the things that we really want to highlight is that, you know, we have our genotype, which we may not know what that is. And then there's the phenotypic expression of said genotype. And that many of these conditions have a high degree of variability in the penetrance of the genotype that they have. And so much of our conversation around screening really is a relationship that persists over many years when we're worried enough that a kid may begin at some point in time to manifest the physical manifestations of said disease. So I think that's also why we like to see and then develop that rapport with the family and see them over time, because things can change. So I'll use the example, which I'll get into here in a moment, of a child that has a family history of hypertrophic cardiomyopathy. That kid may not begin to have echocardiographic manifestations of changes to their left ventricle until they're in their late teens or maybe even early 20s. And so that's why when we talk about screening, it's just not a snapshot in time, but it's something that happens over oftentimes the lifespan of that patient. The other piece about the information, that information is so critical when we kind of delve into the family's history. And we recognize in a 20-minute visit, you don't have that luxury, which we do. And so we don't always expect you all to dig into that. But if you can set the stage for the family and say, the cardiologists are really going to need as much information as you can get, that's really helpful. And that information also includes, if there's a death, autopsy results too. And we'll spend a little time at the end, if we have time, talking a little bit about that circumstance where there's been a family death and what do we do in those circumstances, which can be tricky. But we're often asking for autopsy results. If that's the case, that can be a really sensitive conversation, certainly if it's relatively new. But that information can be immensely helpful as we try to risk stratify other family members.
And Matt,
go ahead, Aaron. Yeah.
Well, I just say, really, the screening that I meant on this first section was on the parents, not the kids. We're going to talk about that separately. But a lot of times it's, parents are a lot, obviously, older than the kids. And so getting a screen on them, they've had a lot more time to kind of manifest. But still, if they're young parents, that doesn't necessarily mean that they would be a one and done is what they need. They may need ongoing screening. But certainly this first section, we'll come back and talk about kind of screening and follow-up of kids, but that was more meant for the parents.
Understood. Next slide, please.
Okay.
So we've got 3 buckets and a cup that we're going to cover in our next half. And so the 3 buckets include cardiomyopathies, arrhythmias, and aortopathies. And then our Starbucks cup is early MI. And we'll spend a little bit of time talking about early MI because we do get a lot of referrals about that. And I think we're here to manage expectations a bit, and that we're not always quite able to really risk stratify kids in the setting of a family member that had an early heart attack. But we'll talk a little about that. But we'll lead with cardiomyopathy. We can go to the next slide. And there's many different examples of cardiomyopathies in kids. There's hypertrophic cardiomyopathy, dilated cardiomyopathy, restrictive cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, ARVC or ARVD as sometimes it's called, and then left ventricular non-compaction. I'm going to talk just about hypertrophic cardiomyopathy and dilated cardiomyopathy. But certainly ARVC, left ventricular non-compaction have similar genetics and inheritance patterns. But we'll highlight the first 2 because those are the most common that we encounter and deal with. But a lot of what we're going to talk about, there's a lot of overlap with the other forms of cardiomyopathy. So we can go next slide, please. And just as a kind of an overview too, is that we know that there's a lot of genetic cardiomyopathies that have a lot of genetic basis, both in children and adults. And just as an example, in dilated cardiomyopathy patients, about 20% of those kids will have a first-degree relative that have some modicum of myocardial dysfunction. So may not have like the complete phenotype of dilated cardiomyopathy, but have some inklings that there's something wrong at the cellular level with their myocardium that is genetically based, that is then kind of percolates through the family. And then then hypertrophic cardiomyopathy, about 50% of patients will have an affected first-degree relative, just kind of speaking to the prevalence of the disease, the autosomal dominant fashion which it is inherited, and whether or not we have an identified gene mutation or not, still that high prevalence. We can go to the next slide and I'll talk a little bit more about hypertrophic cardiomyopathy here. And just as a quick review, basically it's an echocardiographic diagnosis, but at the cellular level, it's a myocyte hypertrophy, the myocyte, the kind of the functional unit of the myocardium, that is thickened, in disarray, and under a microscope, there's a lot of additional fibrosis, and instead of the very neat syncytial patterns of myocytes that are laid down in a very organized fashion in the setting of hypertrophic cardiomyopathy, it's quite the opposite. It's very disarray. There's inflammation and fibrosis I talked about that leads to the actual phenotype of a thickened myocardium. But then also what puts these patients at risk is then ventricular tachycardias, ventricular arrhythmias as a result of this fibrosis and disarray. That is what can be in the final common pathway of what it becomes life-threatening. It's just that, as the patients have lethal arrhythmias, which, if they are not attended to urgently, can die as a result. And it really is kind of a disease we talk about at the sarcomere at the cellular level. Relatively high prevalence in the general population, about 1 in 500 people. suspect have hypertrophic cardiomyopathy. And certainly in our young healthy adolescents and athletes and young adults, it's the most common cause of sudden cardiovascular death. The genetic transmission is certainly more common than we recognize in other cardiovascular disease, which is an autosomal dominant inheritance pattern, as I shared. And as I said, the diagnosis is made by echocardiogram, and that's really the tool that we use for screening. Serial screening is echocardiograms. And I just have a quick schematic here, and I'll just draw your attention to these 4 boxes. It's different views of the myocardium, and you know, you don't have to be a cardiologist to see that this is the left ventricle, and that septum is really thickened and hypertrophied both in multiple planes. So that's the short axis that Aaron's highlighting there. That is not how the heart myocardium should look. It has kind of a heterogeneous appearance. Oftentimes the function is preserved. When it's not, we begin to really worry that that's a patient at risk for lethal arrhythmia, and in those circumstances, often those patients either have an ICD or are on a heart transplant list. But this is commonly what we're seeing. Obviously, this is the severe end of the spectrum, but it can be subtle. But this is how we make that diagnosis. When we have a first-degree relative that we know is affected by hypertrophic cardiomyopathy, the recommendations that we share with families that they should be screening their children. Again, if we're talking like children or siblings, every year to every other year, starting around the age of 12. And that's American Heart Association, American College of Cardiology recommendations up to the age of 21. I think most of us, if we had a child, a family member that was under the age of 10 to 12, we would at least get 1 or 2 baseline echocardiograms. So if I have a 2 or a 4-year-old who's got an older sibling or a parent with hypertrophic cardiomyopathy, I'm not going to wait until they're 10 to 12 to get that first echocardiogram, but I wouldn't necessarily get it as frequently until they turn 10 to 12 in that peripubescent age range. The European Society of Cardiology recommends that starts at the age of 10. So there's a little bit of difference between kind of expert groups, but on average, we start around 10 to 12, around the time of puberty when there's a lot of linear growth, a lot of endocrine changes that can be the impetus that triggers or begins to trigger the change that we might see echocardiographically. These kids may have an ECG abnormality, and so they may have LVH, so that's a really poor correlation. LVH with strain, a little bit more sensitive that there's a true echocardiographic finding. And then we talk about, our fellows always about T-wave abnormalities, and T-wave abnormalities out in the lateral precordial leads that are flipped and stay flipped certainly raises our index of suspicion that there might be something wrong with the myocardium. But the ECG is just not a good screening tool. So let me rephrase that. It is a screening tool that is helpful in the context of trying to identify undiagnosed hypertrophic cardiomyopathy. But if we have a first-degree relative that is known to have hypertrophic cardiomyopathy, we're going to be screening, and they don't have like a genetic testing, and we'll get into that towards the end of this talk today. We're doing serial echocardiograms on a yearly or every other year basis. Some of the genetic testing that we might perform in our cardiomyopathy panels, the 2 most common pathologic variants that we see with hypertrophic cardiomyopathy are the MYH7 and MYBPC3 mutations. I just put that out there just kind of so you've seen it and heard about it. Not that I expect anyone to remember that. So next slide, please, Aaron. So just briefly about dilated cardiomyopathy. So what we see with dilated cardiomyopathy, these patients have dilated left ventricles with shared left ventricular systolic dysfunction. A myriad of causes, so a little bit different than our hypertrophic cardiomyopathy. You can see dilated cardiomyopathy as a product of myocarditis, metabolic disorders, myocyte protein disorders, toxins, coronary artery abnormalities that have true, like, rooted in structural cardiac disease, nutritional deficiencies, or arrhythmias. So there's a myriad of causes of secondary dilated cardiomyopathy, but the primary insult may be something structural or related to an infectious insult or some nutritional deficiency I shared with that. What I'll kind of highlight is that the genetic forms account for about 40% of those that involve kind of a myriad of the sarcomere or the myocytes. And in those cases where we know there's a genetic component, it tends to be in the pediatric form somewhat of an autosomal recessive inheritance pattern, but in our adult familial forms, it's more of an autosomal dominant with kind of this incomplete and age-related penetrance that I alluded to as well, with a large degree of variability in the phenotypic expression of dilated cardiomyopathy. So dilated cardiomyopathy is a little bit more complex in the genetics of it, but certainly if there is a affected family member, so I'll kind of come back to those 3 questions I posed where I used Marfan's, but take out Marfan's and insert dilated cardiomyopathy. What's our diagnosis and screening tool? Again, it comes back to an echocardiogram. And similar to hypertrophic cardiomyopathy, we're going to be performing annual to every other year screening around that 10 to 12 year age range up until they're 21. Once patients turn 21 for both dilated and hypertrophic cardiomyopathy, they don't have changes. The recommendations are to start to space that out. They feel like that risk starts to fall off, and the recommendations are about every 3 to 5 years. So we don't want to lose those patients to follow up. And so that's why we really try to foot stomp for our teenagers, like, hey, you're going to need a good primary care manager. You're going to need to continue to be screened. But the recommendations are that they start to fall off and the frequency is not as often. And again, ECGs can be very nonspecific. Next slide. I think now I'll turn it over to Dr. Olson for discussion around the aortopathy.
Thank you. So I'm going to talk about aortopathies. And some examples of these are Marfan syndrome, Loeys-Dietz syndrome. I would argue bicuspid valve fits in this bucket. And then thoracic aortic aneurysm and dissection, so-called TAD disorders. And then I'll mention Ehlers-Danlos syndrome because that's a common referral that probably or may not always need to come to cardiology. So just to review, aortopathy is the term that I use to share these. It's a spectrum of conditions predisposing to dilation, aneurysm, dissection, or rupture of the aorta and other blood vessels. And this is a old school MRI scan showing the aortic root. And this is where the dilation often occurs with these disorders, but not necessarily. And I will point that out a little bit later. Some of these aortopathy conditions can be syndromic, meaning they have physical features that are pretty obvious, such as Marfan syndrome and Loeys-Dietz syndrome. And some of them are non-syndromic, like the TAD or bicuspid valve, meaning that you can't look at a patient and determine whether they have the syndrome or not. Marfan syndrome is the most common and probably the one that we're all most aware about. It is an autosomal dominant condition with a change in the FBN1 gene. The incidence is about 1 in 3 to 5,000, so less common than hypertrophic cardiomyopathy, but still fairly common. The diagnosis is made by the revised Ghent criteria, which includes genetic testing as well as aortic dilation, some eye findings, and other musculoskeletal features that are very well known to many of you. So Marfan syndrome, it's a systemic, it's a syndrome, right? So it affects the eyes, most commonly something called ectopia lentis, but patients are often very myopic. They have skeletal or skeleton changes, tall stature, pectus excavatum or pectus carinatum. They have skin changes like stria. Whoops, that's over here. Stria on their shoulders or back. A lot of people get stria on their buttocks, but that's normal. But stria that's on your back or shoulders can be associated with Marfan syndrome. They also get lung disorders, especially spontaneous pneumothorax. Other cardiovascular issues that they can have is mitral valve prolapse, and in certain form of Marfan syndrome, especially what we call early onset Marfan syndrome, mitral valve prolapse is is the predominant feature, and it's actually what creates the heart failure and problems early on in the early onset form. Treatment, I'm not going to get into very in depth on this, but we often use medications to slow the rate of aortic root growth. We do regular screening, and then when the aorta gets to be at a certain size, when we predict that the risk of surgery is less than the risk of a dissection, we will recommend prophylactic aortic root replacement. Loeys-Dietz syndrome is another kind of overlapping syndrome with Marfan syndrome. But genetic testing, I think like in the early 2000s, identified that it was a separate disorder. I think a lot of times these people back in the day used to be called Marfan syndrome. So this is also an autosomal dominant condition. And there's at least 6 genes that are associated with Loeys-Dietz syndrome. And this is TGF-beta receptor signaling, TGF-beta pathway, if you will remember that. The diagnosis is typically made by genetic testing and clinical findings, especially the aortic enlargement. From the syndrome side, they tend to have an appearance with hypertelorism. They also commonly have or can have a cleft palate or a bifid uvula. So there were many years when I wasn't looking in mouths as a cardiologist, but now we make people open up and show us their uvula. Oftentimes, patients will have club foot or craniosynostosis. And what's unique about Loeys-Dietz syndrome, at least compared to Marfan syndrome, is that they are at risk for aneurysms and dissections outside of their chest. So we end up doing screening on these patients, basically MR angiograms from their head to their pelvis to look for any other aneurysms or at-risk spots. And similar to Marfan syndrome, treatment is medications to slow the rate of aortic root growth, ongoing screening. I didn't list that, but that is part of the management. And then prophylactic aortic root replacement surgery when the aorta reaches a certain size. And with Loeys-Dietz syndrome, we think the risk of dissection is actually at a lower size than Marfan syndrome. So we would typically replace the aortic root slightly smaller than Marfan syndrome. Bicuspid aortic valve is another disorder that we see, and this is not typically syndromic. Bicuspid aortic valve really has a wide presentation spectrum, and sometimes you can pick up patients by hearing a murmur of aortic stenosis, but sometimes you don't hear anything. And so just there's a wide variety. So what we find is that about in a patient, in someone with bicuspid aortic valve, about 9% of their first degree relatives will also have bicuspid aortic valve. So it's not as common. It's definitely not autosomal dominant, but there is some complex genetic inheritance that is present. There's no common gene for bicuspid aortic valve. So differing from some of our other conditions, we don't do routine genetic testing in this situation. There are some exceptions, but generally don't do genetic testing. The diagnosis really has to be made by echocardiogram to look and see. This is a diagram of a aorta in cross section, and you can see this is the opening. Whoops, I'm on the wrong side. I'm sorry. This is the opening. So this is one leaflet up here, and this is the second leaflet. And there should actually be a break between these upper leaflets here, and there should actually be 3 leaflets. I already said the patients are non-syndromic, and what's interesting with bicuspid aortic valve is that they can also have aortic dilation. And actually, bicuspid aortic valve is probably the most common condition for adults to have aortic dissections, because bicuspid aortic valve is just a very common disorder. So when we screen patients, we look at their aortic valve as well as their ascending aorta. The treatment is variable. It depends on the size of the aorta, the rate of growth, maybe whether they have associated aortic stenosis or aortic regurgitation. And like I said, there's no real genetic testing, so screening for this, family screening, is really an echocardiogram. TAD. So this is another non-syndromic cause of thoracic aortic aneurysms and dissection. This is also can be inherited as an autosomal dominant condition. And I've included some common genes, which I won't get into, but when we do genetic testing for a TAD panel, I think it's up to like 27 genes, 26, 27 genes. That includes the Marfan syndrome genes and Loeys-Dietz, which should be more syndromic, but there are multiple genes. The diagnosis for this is typically made in someone with an aortic aneurysm, and then they undergo genetic testing for the TAD panel. These patients are non-syndromic, so I put this intentionally left blank because these patients, you can't look at them and tell that they're at risk. And like our other aortopathies, treatment is with medications to slow the rate of aortic growth, routine screening echocardiograms, and someone that's affected with aortic dilation. For any of these disorders, we will screen them at least yearly, and then prophylactic aortic root replacement surgery when the aorta reaches a certain size that we think is at high risk for dissection. You take a drink pause. I want to talk also finally about Ehlers-Danlos syndrome, or EDS. There are actually 13 types of EDS, which I don't know them all because most of them do not affect the heart, but I'll focus on the 3 most common types and kind of what you should do in those situations. So while not common, the scariest, at least to cardiology, is something called vascular EDS, or VEDS. On physical exam, maybe the patients have kind of thin skin, maybe they bruise easily, but a lot of times they don't have the typical joint laxity of other forms of EDS or skin findings of like a classic EDS. So oftentimes they look very normal, but their family history is remarkable for arterial dissection. So not just aorta, arterial dissections. They can also get organ ruptures, which is probably about as scary as it sounds. Sometimes a woman will have a uterine rupture in pregnancy. They can have intestinal ruptures. So it's a family history, oftentimes of young arterial dissections or organ ruptures. Again, their cardiovascular issues are, and I intentionally use arterial here because it's not just aorta, it's arteries all over their body. So like the Lloyd-Dietz syndrome, we really have to screen them from head to pelvis. And if you have a family that has a history of vascular EDS, that is definitely a person that we want to see in cardiac genetics. Other forms of EDS include classic EDS. And those are the patients that have the abnormal skin. So they'll have the atrophic scars on their knees. A lot of times they have these big scars. Their skin is very fragile. They'll bump into something and it will tear open and they have to go to the emergency room and get their skin glued. Their skin will really be very remarkable. Cardiovascular issues, they sometimes have aortic dilation or maybe some mitral prolapse, but it does not tend to be progressive. So for classic EDS, we will typically ask that those patients be referred to genetics first for evaluation, and then genetics can determine whether to send them for an echocardiogram. The final and most common type of EDS is called hypermobile. And I apologize, this should actually be HEDS. And this is a lot of people, frankly, will come to you and say that they have hypermobile EDS, but when there's actually specific criteria for hypermobile EDS. And a lot of people actually don't have it. They might have some laxity, but it's kind of in the normal variation. The primary exam finding on these patients, again, is the joint laxity, maybe frequent dislocations, very flexible. They also just rarely have cardiovascular issues. Again, sometimes they can have aortic dilation that does not progress to dissection. So maybe so it doesn't progress to dissection, and aortic dilation that doesn't progress to dissection is not necessarily an important problem. And so this would be another group that we would recommend referral to genetics rather than cardiology to get screened. And part of it also, to be frank, is that there's a lot of people that feel like they have hypermobile EDS that if we saw them all of them in cardiology clinic, Matt would have to be working on weekends and nights to see all these patients. So there's just too many of them, and they don't typically have cardiac issues. And so we recommend genetics referral for those patients.
And Aaron, turn over to Matt. Aaron, I think the point about EDS is I think one that probably should come back to is that vascular EDS, the very dangerous, high associated mortality is exceptionally rare, correct?
It's exceptionally rare. Yeah. So to be honest, like in my, I hate to say 20-year career, but I'd probably not seen a patient with vascular EDS up until probably 5 or 6 years ago. And then I started to see more. I think one thing that's interesting is more patients are getting whole exome sequencing or whole genome sequencing. And so probably I maybe see maybe 4 to 5 patients with VEDS. And I think only one of them came to me by family history. The other 4, it's because genetics did a whole exome sequencing and found a pathologic mutation in the gene for vascular EDS. So it is extremely rare, but it's probably, we're going to have more patients now with extensive genetic testing.
Yeah, that's an interesting point about that very issue. It's probably, something that also affects other services, not just cardiology, in the greater context of whole exome sequencing and how common it is now. But certainly the hypermobile type, I think there's a lot of fear that somehow is connected to cardiovascular disease. And I think to your point, it's really, there's not an association there. Now, certainly the connection with potentially POTS, topic for another day, but I think that you can reassure your families that may have a concern for EDS, the hypermobility type, that though impactful maybe on their day-to-day lives, it's not something they need to worry that there's some cardiovascular association with that.
Yeah.
And the only other thing I'll mention too is just the bicuspid valve. That screening with echocardiogram, if we see the aortic valve on FOSS and there's 3 leaflets, they're done. That's the one thing where we don't have to do longitudinal screening for that family, is that we can clear their valve, say it's 3 rather than 2 leaflets, and thankfully that's not something that they may have to worry about in the future. Whereas, and you can go to the next slide, Aaron, whereas in a lot of these, with the exception of maybe like Marfan's and Loeydita, those kids could have some like clear physical GAM phenotypes. I think part of the challenge with underlying cardiovascular disorders that are inheritable is that kids don't usually have the physical manifestations of that. They often have normal exam findings. And so we rely heavily on these screening tools, echocardiogram, ECGs in the context of arrhythmias here that I'll talk a little bit about, to make a discovery, make a diagnosis, or in the setting of where we know there's an affected family member, assess additional family members with these tools. And again, that can change over time. That risk or the phenotypic manifestation can change certainly over time. So I'm going to touch on, there's other forms of arrhythmias. I'm going to touch on 3, long QT syndrome, Brugada, and WPW. So go to the next slide, please, Aaron. So long QT syndrome is kind of this, as the name would imply, it's a prolongation of the QTC, and it's a heterogeneous group of disorders with unified under the characterization of an abnormality with the myocardial repolarization. And so, as the heart relaxes in diastole, this is reflected echocardiographically in our QT interval. And in kids that have long QT syndrome, it's a prolongation of the QTC on their ECG. And usually we have some criteria that we say over 450 to 470, depending on a boy or a girl, where we begin to have some concern about long QT. But we always, I think what's important, and our electrophysiologists talk about, is it truly is a syndrome, and there are criteria beyond just an isolated prolongation of the QTC that we use in aggregate to make a diagnosis if we don't have the luxury of genetic testing. But we worry in the patients that do have long QT syndrome that they are at risk for life-threatening polymorphic ventricular tachycardia and may have symptoms in the way of syncope with exercise, unexplained seizures, sudden death, or aborted sudden death, in the case may be, with a very high penetrance. So about 78% of cases are inherited in an autosomal dominant fashion. It can be certainly de novo mutations, but it really does seem to run in families. And in this case, we manage this a little bit different than some of our other forms of cardiovascular diseases that we've talked about, where if we really do want to try to target and identify a pathologic mutation. And I think on our long QT panel, we're up to like 17 or 18 different types of long QT. but far and away the most common are long QT 1, 2, and 3. And I've just added a little blurb here in a table with some of the unique aspects of all of those 3 and how they might manifest, and then what their ECGs may look like. But if we can identify a mutation, a pathological mutation, it can really help us target how to treat those individuals beyond just some maybe exercise modifications. And we're even kind of becoming more sophisticated in that regard, and not just uniformly restricting patients from physical activity, competitive sports, but we do recommend treatment. So in this case, unlike say with hypertrophic cardiomyopathy, where we're screening serially, and if they don't have any echocardiographic changes, we say, great, continue on with your healthy life, continue participating in competitive sports, and come back and see me in a year or 2. With long QT syndrome, if you have long QT syndrome, we want that kid on therapy. And usually the therapy is a beta blocker, although in long QT, we use something a little bit different, using mixilotine. Because we know there's a lot of data that shows that if kids are compliant with their medication therapy, their risk of sudden cardiovascular death goes way down, is exceedingly low. So that's where really having a genetic diagnosis, tailoring pharmacotherapy can really be critical and life-saving and really disease-altering. And one of the other pieces that I think it's important is that there's probably about 5 to 7% of patients that have long QT syndrome that have normal QT intervals, which is a little scary, or may have variable degrees in what their QT interval actually is. And so we certainly, if we know, if there's a genetic mutation that we have identified, we highly recommend to families that we target test their first degree relatives. But if, say, we don't know, or the family is choosing not to be targeted tested, and in this case, we would press that family. But if they which is their prerogative, they decline, then we recommend kind of annual screening ECGs every few years when their kids are under 10, and then through puberty up to age 21, annual ECGs as well, looking to see if they have changes to their QT interval that may not have been present beforehand, but then evolve. We usually do exercise test those individuals too, looking to see if their QTC prolongs during exercise, which would be pathologic, and in all of this usually it shortens to allow for accommodations in heart rate. Next slide. So Brugada syndrome, briefly, pretty rare, not as common as long QT, but it is an ion channelopathy. In this case, it's related to the SCN5A mutation. These kids have a classic ECG finding of a right bundle branch block and ST segment elevation in V1, 2, and 3 that Aaron is highlighting there. And since it's nice that you have seen and heard about it. In this case, we have a similar approach with long QT. We do want to test if there's a known mutation, test first degree relatives, and looking for that specific mutation, because if they don't have it, then they don't have the risk for Brugada or long QT, as the case may be. And then if not, we recommend serial ECGs. There's some additional things we can do to try to see if someone's got Brugada, something called procainamide challenge, where that may bring out the ECG findings that may not be present at baseline. But again, that's not necessarily information you need to be aware of, just to have heard it. And next slide. We get a lot of referrals for WPW. WPW, Wolff-Parkinson-White syndrome, is a microscopic accessory pathway with a classic ECG triad that we're seeing here. And the 3 components of that are a short PR interval, a delta wave or the pre-excitation, and a prolonged QRS as a product of the delta wave and that short PR. WPW is puts kids at risk for SVT, and again is fairly common. Thankfully, when not associated with hypertrophic cardiomyopathy or Epstein anomaly, so I'll kind of just throw that out there, but then now let's put that aside. It's really thought to be non-genetic. And so in this case, we usually don't screen relatives, and we tell families with a fair amount of confidence that just because you had WPW or you have a child with WPW doesn't mean that you or your children are at risk. Now, that's not to say that if the family wanted to screen an ECG, that I would say no. And in fact, there's probably a role for everyone to have an ECG at some point in time in their lives. But to reassure families that it's really not something that's rooted in a genetic cause to that, and therefore families can feel confident that often when it's seen, it's in isolation and not something that other families need to worry about. Now, all that said, there are some rare familial clusters, but that is far and away the exception and not the rule. Next slide. So lastly, just quickly, so we can have enough time to talk about our final bit, but early MIs really doesn't usually require a cardiology referral. How do we define early MI? Is a heart attack under the age of 50. So heart attack in the 50s, though young, isn't really technically an early MI. You know, the conversations we have with our families are like healthy lifestyle conversations that you too can have with your kids. You know, recommend a screening cholesterol when they're in that peripubescent age range, like the AAP recommends. And then if that's abnormal, our endocrine colleagues have a clinic that's specifically identified to support patients that have hypercholesterolemia that runs through their families. But early MI is really not something that we feel needs to be screened in any capacity, short of just the importance of healthy lifestyle conversations, exercise, avoiding sedentary lifestyle, making sure your blood pressure is not elevated, not smoking, all those things that certainly apply to us all. But that I think a lot of times those visits are important, but not necessary per se, and that those kids don't need ECGs, don't need echocardiograms. We're not going to change that trajectory. Always have to have a conversation about healthy lifestyle choices, but not something where we can offer them a whole lot. We'll go to the next slide because I know we've got some more important things to talk about in the last 5-10 minutes.
All right. So I'm going to talk now about after referral. So the cardiology evaluation and monitoring. And we covered some of the specifics on our previous disorders, but this is kind of our general approach. And I'm giving you more buckets, but this time no cup. So basically, when we see a patient, we have one bucket is that the family genetic testing has been positive. A second bucket is that the family genetic testing has been negative. And then the third bucket is that the family genetic testing has not been done or not done. And again, this also assumes first-degree relative is affected. So this is how I would think about a patient in clinic if they had a first-degree relative affected. And just a quick comment on genetic testing and family, and this is for you, but it's also for families to maybe prepare them or set some expectation, is the testing needs to be done on an affected family member. So in an unaffected person, a negative genetic test could mean that they don't have the disease or that the family has a novel pathological mutation. So sending a teenager that we screen, they look normal, doing genetic testing on them doesn't really provide us useful information about their long-term risk. We really want to get that genetic testing on the affected family member. So the first bucket is family genetic testing is positive. Again, that would be for any of the disorders that we've already spoken about that have genes identified. So really, in this situation, the patient really needs targeted genetic testing. And so probably the best way to get that done is actually a referral to a genetic counselor. And certainly our genetic counselors at South Children's Hospital do that targeted testing all the time. So I would advocate that as a first step. If it's a patient that they can't get in for the genetic counselor and they have football or soccer coming up in 3 weeks, then it's not unreasonable to send them to cardiology to just do the cardiac screening to clear them for sports. So if someone gets targeted testing and they're positive, then they fall into the cardiology pathway. They see Dr. Studer in his dressed up suit for the cardiology evaluation and ongoing monitoring. But if their targeted testing is negative, they don't need to see cardiology for that problem at all. So that can be very reassuring, and it can save a lot of extra cardiology visits and echocardiograms, which are actually much more expensive than targeted genetic testing. The next bucket is when the family genetic testing has been performed on an affected individual, but it's negative. And this is really probably, for me, the hardest situation. So these patients need cardiology referral, and they're stuck in a pathway of ongoing screening. They just can't get out of it because we can't essentially rule out that they don't have the disorder. So the screening, again, is based on the specific disorder and the type of screening. If it's an arrhythmia, it's EKGs. If it's hypertrophic cardiomyopathy or, thoracic aortic aneurysm, then it would be more echocardiograms. But these patients are really stuck in cardiology ongoing screening. Now, one thing it's interesting, just to remember, is that the sensitivity of genetic testing is constantly improving. So testing the affected person should be repeated every 5 years or so. So just because they had negative genetic testing for hypertrophic cardiomyopathy or aortic aneurysm panel 5 years ago, we're discovering new genes for that. So a lot of times they will recommend repeat genetic testing again every 5 years. That's just a rough estimate, but at some interval, because you might actually detect a difference over time as we learn more. The final bucket is when family genetic testing is not done. So again, like I showed very early on, what really needs to happen is that the affected individual, we really need the affected individual to get genetic testing. So sometimes that involves us reaching out to their cardiologist or writing a letter. In the meantime, cardiology referral for the child is appropriate. And if we do the workup, again, the echo or EKG, and we find that they are phenotype positive or they're affected, then we would, of course, start treatment, but then we could do genetic testing on that child. So we're a little bit in the situation where we don't necessarily need now that genetic testing on the affected individual because we can do the child. If the child is unaffected, meaning on that initial screen, not on multiple screens, but if they are unaffected, they are kind of stuck in the pattern of the negative genetic testing. So they need ongoing cardiology screening. In the visits, at least when I have patients like this, I'm sure Matt does the same thing, that we remind the affected person to get genetic testing so that we can do possible target testing on the child. And, a lot of times adults are not great about going to their doctor or pushing this, but really when you emphasize this is really important for your child to know, people are more likely to do that testing. And then again, if we can get that affected person to get that testing and something is identified, then we could do targeted testing on that unaffected child and determine whether they really need that ongoing cardiology testing or whether we can discharge them from clinic. All right, Matt gets to take us home and wrap it up.
He's my least flattering photo. I appreciate that, Aaron. So the conversation around genetic testing is certainly charged. We spend days talking about that, whole seminars. But just kind of in summary, it's important to understand is that there are many inheritable cardiac conditions that have a clear autosomal dominant pattern of inheritance. We really want to highlight the importance of screening first-degree relatives and the infected individual. Of the infected individual certainly is important. It's something we want to do longitudinally. That screening can include genetic testing, and when we identify in the affected individual that proband, and when we can identify a known disease-causing mutation, we can certainly use that to our advantage and use that in how we counsel families about potential modality to screen in or out for disease. If they choose to do so, great. If they don't, or we don't have that luxury, then really screening becomes serial ECGs, echocardiograms of those unaffected kids longitudinally over time. That's the last thing to comment on is that really the complexities, the genetic complexities of cardiovascular disease and the impacts on families and patients certainly is expanding. I mean, Aaron alluded to in this modern era of whole exome, whole genome sequencing, and that really is becoming quite a game changer. The discovery of a lot of genetic abnormalities, a lot of variability, variations of unknown significance as well. Those VUSs too, that can make the dynamic of how to then counsel families and assess risk very complicated. We certainly need more geneticists in this world and genetic counselors that are worth their weight in gold. But we continue to learn a lot, continue to apply that then knowledge to kind of how we risk stratify families and support families through this stressful journey that they're on. And we obviously want to recognize that the impact it has on families, and it's difficult, and certainly the uncertainties can be hard. So we have a few minutes left. Certainly appreciate everyone's time and attention and participation today. Available for questions, or Aaron, if you have any additional comments, we want to open up to the group to share comments or questions that they may like.
I don't really have any other comments. Would love to hear some questions.
Thank you both. I'm looking through the chat. I don't see any questions in there just yet. And I don't know if anyone has any questions they'd like to ask verbally. But if so, feel free to raise your virtual hand and we can unmute you.
While we're waiting, one thing I'll mention, and we didn't have, are there any downsides to genetic testing from Krista? Thanks, Krista, for that question. And you know, I think that the answer could be yes to that. And I think when we counsel families about genetic testing, it's certainly not a panacea. And the downsides, I'll say, and I bring this up a lot of times to families that have like hypertrophic cardiomyopathy or dilated cardiomyopathy, is that if you identify a mutation in your child, but they don't have the phenotype, so they have the genotype but not the phenotype, there can be some downsides to that. Certainly just the emotional trauma associated with recognizing you've got a genotypic abnormality that can predispose you to a certain life-threatening condition. But then also the effects of life insurance, potentially for health insurance, which may exist even in absence of having any of the phenotypic expression of the genotypic disease. So for some families, they need to know. If they've got an identified mutation, they're like, I need to know, I need to test my kids to know they either have it or don't. But in other families may choose, like in light of that information, to say, well, are you still going to screen my child with annual or every other year echocardiograms? The answer is yes, even if we don't test them. And that may be acceptable until that child becomes of an age that they can make their own decisions when it comes to their own healthcare choices, with the impact not only them, but potentially in the way of family planning. So it is absolutely a charged topic, which does have some potential downsides that we want to be very open and transparent when we talk to families about testing.
Yeah, and the other issue, I mean, I think about life insurance. I don't know that genetic testing, because if you have a first-degree relative with hypertrophic cardiomyopathy, you probably have to list that on your life insurance, which probably would increase your rates. I don't know if it increases your rates more if you also have the genotype, but certainly if you're genotype negative, that would probably be a relief and allow you to get life insurance. You know, one of the issues is variants of unknown significance, which is why, again, we don't like to test unaffected individuals, because there can be a VUS that you don't know, a variant of unknown uncertain significance that you don't know whether it's pathologic or not, and then they're stuck with that for many years until they figure it out. And I'll also agree with Matt, like, you know, sometimes we do delay the genetic testing consideration until people are a little bit older. But I think there's also not a small number of families that want to know early on, because, you know, for Marfan syndrome, there's a lot of screening even early on. Hypertrophic cardiomyopathy, you may choose to steer your child into different sports or activities if they have hypertrophic cardiomyopathy or Marfan syndrome. So, you know, I think I'd like targeted testing, I guess. I don't know. But it's a family's decision, definitely.
Yeah, I think that there's absolutely a role. I try to make sure that, you know, through informed decision making, that, you know, families understand what are the ramifications of that and the limitations, and so that's where we involve our genetic counselors as well. Yeah. There's a question about nick of time and ECGs. I'm a strong advocate and proponent for the nick of time and the work that they do. I actually just volunteered with the event that they had this past weekend at VMAC, which was super cool. And we screened about 550 kids. I do think every kid deserves an ECG at some point in time in their lives, and the Nick of Time Foundation is a foundation that really pushes that in the high school level, which is great. And so I absolutely, just to specifically answer that question, I do agree with an ECG and foundation. We are past 7 o'clock. I'm certain everyone's got things to do, either dinner or families to attend to. So just want to say thank you so much for joining us this evening. And both Aaron and I are certainly resources if you have questions offline. And I know Aaron's going to send out a copy of our slides today.
Yes, thank you so much, Dr. Olson and Dr. Studer. Thank you all for attending tonight. I put a link to the evaluation in the chat. I will also send that out tomorrow morning for anyone who didn't grab it this evening. And we will send out follow-up materials, a link to the recording, as well as a copy of the slides in about a week. If you are not one of the 230 plus people registered for our measles webinar on Friday, and would like to be, I will also send out a link to that as well. No shade to our awesome cardiology team, just a very topical subject.
All right, we understand. We understand.
All right, have a great evening, everyone.
Thank you. Good night.
Bye.
everybody.
Thanks, Aaron. Thanks, Aaron's.
Good night.
Good night, all.